Ladies and gentlemen, it is said the last session of the day is usually boring. It's kind of tiring, and of course, it's like a heavy day. But I am so proud to tell you that the last session on the first day is certainly going to be the best session of the world's first virtual implant expo. I say that proudly because of a very special speaker that we have amongst us. Ladies and gentlemen, most of you all know her. She's a name synonymous in the Indian Orthodontic Society, as well as a talented academician, as well as for everything that she's been doing. The first time we DentistChannel.Online had the opportunity of meeting Dr. Saloni was for a 3D printing session that took place in her college in Mumbai, India, which is called as YMT Dental College. And since then, Dr. Saloni has always been a friend, a mentor, a well-wisher, and has always said yes for anything that I or my team has requested. I cannot really be more happy than proudly telling you of the fact that she's always been there for us, and whatever we are, it's always because of people like Dr. Saloni Mistry and all the other well-wishers that we've had. Thank you so much, Dr. Saloni Mistry. I think the last session for for this evening would be the most power-packed and the much-awaited session. Ladies and gentlemen, we have with us Dr. Saloni Mistry. Well, most of you all know her. I think she's a person who really doesn't need an introduction. But just to tell you in a short introduction, since we are running short of time, Dr. Saloni Mistry is a professor and the head of the Department of Orthodontics at YMT Dental College and Hospital, which is based in Navi Mumbai, India. She's a well-known clinician and an academician for the past 20 years, with numerous national and international publications to her name. She's the EC member of the Indian Orthodontic Society and has been a keynote speaker for various conferences and PG conventions. She specializes in creating aesthetic realism in orthodontic rehabilitation. Without much further ado, ladies and gentlemen, the last session, the most power-packed session. The stage is set. Saloni, ma'am, all set for you. Thank you. Over to you.
Thank you so much, Rubin, for the kind introduction, your kind words. I'm quite humbled. So greetings for the day, all of you around the globe. My namaskar, my hello, my good evenings, and a very wonderful session to begin with. Just give me a few moments to share my screen. So I always begin with a prayer, and particularly the year 2020, wherein we have to begin in this pandemic era, and we need to begin with this prayer of lead us on, let us stand through the storm, through the night, lead on to the light. This particular year, we have been faced with curious case of seas. COVID-19, China, contamination, curfew, confinement, contention, and with the positivity of courage, cooperation, clarity, cleanliness, and care. So a very warm greeting from me, Dr. Saloni Mistry, my department, and at YMT Dental College, GD Pol Foundation, Navi Mumbai, Kharghar. A bow down in gratitude to Mr. Rubin and to the Dentist Channel Online for this wonderful first virtual dental implant expo, and to give so much of sharing of the learning which is happening all around the globe. So as we ponder, we do understand that preservation of natural dentition with minimal invasive protocols has been our foundation for clinical decision making. The choice of treatment planning has always been controversial, as is the definition of a compromised tooth. So how do we decide our treatment planning whether to save or extract a tooth? Well, it has been believed unanimously that implants must replace the missing tooth and not replace the natural tooth. So here I am today to take you to the journey of diligence in decisions, implant versus FDP, which has been a battleground since the era of implantology has completely covered up and changed our thought process of treatment planning. Why have I chosen the word diligence? Well, diligence means careful, conscious, and persistent thought process in our treatment planning, which we are presenting to our patients. And our treatment planning has to be based on clinical expertise, meeting the patient's needs and preferences, and definitely based on the clinical evidences and scientific basis. We have seen in the past 2 decades a paradigm shift from fixed dental prosthesis to an implant-supported rehabilitation. And we can now proudly say that implant prosthodontics has become the first-line strategy for oral rehabilitation procedures globally. But do we understand that how do we define success or failure related to an implant? Is it successfully integrated or is it a restorative failure? Let's come to what success and survival is basically defined as. Is it remaining in situ free of all complications, or survival which is with or without modifications? Well, performance and predictability play a very important role when we are talking about the meta-analysis of a 10-year survival and failure rate of implant versus FDP. Hence, when we look back into scientific literature, we see a 5-year survival rate of 93.8% and a 10-year of 89%, wherein an implant-supported prosthesis has a 10-year survival rate of 89.4%. Also, when we are talking about the conventional fixed dental prosthesis, in root canal abutments, we talk about a 57% failure rate, whereas in healthy pulp, which would probably show a failure rate of 69%. So that's why when we are talking about survivals, a root canal treated tooth would obviously have a more possibility of failure as compared to a healthy abutment. So what are we looking at for an ideal abutment when we are talking about a choice of restoration or treatment planning to our patients? Well, the remaining coronal structure has to be minimum 3 to 4 millimeters in height. The occlusal convergence, as we've all been taught in our undergraduate, postgraduate level, has to be 6 degrees, and it has to have a circumferential ferrule in case of questionable abutments or endodontically treated teeth. But in teeth with questionable prognosis, can implants be called as the better tooth or the more reliable abutment? Well, that's an answer yet to be formed. We obviously know that the shortcomings of a fixed dental prosthesis, which has been always our choice of treatment planning since so many years from the golden era, we are sacrificing virgin abutment teeth. And when you're talking about a young patient, the longevity of an FDP is 8.3 to 10.3 years. That means numerous replacements would be required in such a case. The past decade has shown that the survival rates of implant-supported crowns has been growingly increasing because of the trend of the implantology setting in, as well as the contemporary science of dental materials, which has proven to be better. So what are the factors that affect the treatment choice? Obviously, our patient perceptions and expectations, as well as education to make a legitimate judgment. Economic concerns and anxiety in India are still a concern, and obviously the clinician's expertise and barriers. So it's how you think and not what you think that makes you actually decide your treatment plan. Frank Spears spoke about aesthetics, function, systemic diseases, and biology as a combination of all the factors that would actually rule your treatment planning. So let's now again decide that which way would the pendulum swing and which pick of choice would we make in our treatment planning. Why has implant become a more preferred treatment modality? Obviously because it preserves the pristine teeth, avoids tooth hypersensitivity after tooth preparation, avoids elective endodontic treatment because in 11% of teeth post-preparation they require in endodontic treatment. It improves the access for oral hygiene. There's enhanced gingival response as compared to FDP with subgingival finish lines, and there are fewer complications related to implants. So can we call that implants are the dental panacea for all form of restorations or missing teeth? Well, let us begin the journey of the curious case of complex clinical scenarios which present a challenge to the clinicians to decide what would be the best treatment planning for our patient. We begin with endodontically treated abutments or tilted abutments. Well, in cases where the restoration of the adjacent teeth is required or they are endodontically treated, probably giving a FDP would be a discrete choice rather than maybe giving an implant. However, again, there is a controversy about the survival rates of endodontically treated abutments over an FDP, plus when you're comparing it with a single lone standard implant. When a tilted abutment requires correction, an orthodontic uprightment is not going to take, or probably it's questionable. In that case, giving a 3-unit FDP would be a preferred treatment of choice. Many a times in the maxilla, we are presented with inadequate bone height, which warrants an indirect or direct sinus lift procedure. Well, in every case, a surgical burden is always a sense of concern to a patient. And if the systemic conditions are not proper or favorable, then sometimes a 3-unit FDP is better than going in for surgical procedures like direct or indirect sinus lifts. In case where we have occlusal plane corrections with an orthodontic intrusion, like as for what you can see in this case, that the upper molar has migrated down and the interocclusal space is very, very minimal. In such a case, an occlusal plane correction is primarily the first line of treatment before the prosthodontic phase starts, only after which the implant has to be placed and then the restoration is planned and the final prosthesis is given to occlude in proper contacts. So obviously, the elective orthodontics is necessary to correct the occlusion plane. Anterior aesthetic zone. It has always been a challenge for even an able clinician. So let's look at these, wherein we are presented with the aesthetic challenges of peg laterals or differential gingival zeniths, fractured teeth or periodontally compromised teeth, wherein the patient presents with you with such a challenge. And sometimes, disastrously, we begin or probably begin to face aesthetic failures, which obviously is not what we are looking at. So how do we judiciously plan our implant treatment in our aesthetic zone, which promises aesthetics and aesthetic realism in the anterior rehabilitation zone? Well, we all are accustomed with the ITI treatment guidelines. We have the comfort and the danger zones in the anterior implant placement, and we have to have our basics clear related to the mesodistal placement, which has to be away from the adjacent tooth at least 1 to 1.5 millimeter. In the orofacial dimension, it has to be palatally placed with at least 2 mm of labial facial bone to be present, and as well as the basic orientation of the implant should be in congruence with the cingulum of the adjacent teeth. In the corona-apical direction, the comfort zone is obviously where the implant is positioned 1 mm apical to the CEJ. So these are the 3-dimensional ITI guidelines which we have to primarily decide and also place the implant strategically so that we avoid any form of prosthetic concerns during rehabilitation procedures. As we all clearly know that implants is particularly a prosthetic driven implantology treatment. The periodontal biotype. As we all know, the thick biotypes are a little more forgiving and probably would give us more excellent emergence profiles than the thin biotypes, which would require higher level of diligence for precision. Now let us look at this case, your clinical picture that you can see here. You can clearly make out that there is a apical migration of the soft tissue. And if we see the vertical distance, which is ideal from the crest of the bone to the height of the interproximal papilla between the adjacent implants, has to be not more than 5 mm. If that distance is more, particularly when you see between the CEJ and to the crest of the, if a 3 to 4 mm distance is more between the CEJ of the adjacent teeth to the crest of the bone, then the papilla is going to be depressed or you're not going to have a papilla fill. Now, what are we going to do in particularly this case where we are going to place an implant and then try to create a good soft tissue profile? Where before placing an implant, orthodontic extrusion is very, very important, because the orthodontic extrusion will carry the bone as well as the soft tissue along with it coronally, give us a better hard and soft tissue profile, after which the implant can be placed to have a better emergence profile. Many a times, we are presented with decreased interproximal space. Very typically, either if we have a congenitally missing lateral incisor, and or there is a migration of teeth with long-standing edentulousness. Interventional orthodontics is extremely important in such cases, so that before we actually place an implant, you have to create that space before you actually place an implant and then go in for a restoration. In congenitally missing lateral incisors, again, interventional orthodontics is very, very important. And after that, the implant placement is done. As you can see in this case, wherein clearly you see that the space is gained after orthodontic intervention, and then the implant and the restoration is carried out. A good emergence profile is the skill of a prosthodontist. Well, as you can see, customized impression copings and customized abutments are the need of the hour, particularly to create good emergence profiles in the lower edentulous span, particularly the lower anterior teeth. So that's something which we have to bear in mind when we are dealing with a progressive kind of building up of the emergence profile in the lower anterior region. As opposed to periodontally compromised lower anterior teeth, to avoiding occlusal lower overload, if we are planning to place a single implant in that edentulous span, then mind you, we have to be very careful that the occlusal load should not come on the single implant, which will bound to fail, and hence it has to be distributed all among the adjacent teeth. So again, this treatment planning is whether to splint the teeth with an FDP or give a single implant and then distribute the load in excursions, lateral and protrusive excursions over the teeth, is the judicious of a skilled and planned prosthodontist. As I spoke about splinting, we also understand that there has been a lot of controversy whether to splint implants or not to splint implants. Well, the literature speaks that one implant connected to one tooth or a block of teeth is still permissible. However, splinting is a lot of controversy. Very obviously, we do understand that the vertical movement under occlusal load of a tooth is primarily much higher, which is 28 microns, as opposed to 2 to 5 microns in an implant, which is again because implant is osseointegrated and tooth has a periodontal ligament, which is causing the kind of mobility. The horizontal movement of the tooth is much more in anterior teeth than in posterior teeth. So we have to take care that the occlusal load, or rather the occlusal load, if there is more over the implant, then obviously the implant would ail and eventually fail. So that point of splinting is something which has to be very judiciously done. In case the ITI guidelines are not followed, and as we say, this is a kind of compromised emergence profile which sometimes we are faced with when we have a labial positioning of the implant, when there's a vertical bone defect and we are having a labial positioning. So that's the kind of positioning where it's prosthetically it is impossible to try and get the aesthetic realism. And this is obviously an aesthetic failure for prosthodontists. So we don't want to look at the implants which are right now the very promising treatment modality, which is giving aesthetic failures and just serving in function. We want the patients to understand that it is a blend of aesthetics and function, and we are responsible for getting that blend successful. We go on to many a times the FDP with Ovate Pontics, when we want a better soft tissue profile. Many times the patients are a little more concerned regarding surgical protocols. And when surgical burdens are not supposed to be addressed to, then an Ovate Pontic again proves to be a preferred treatment of choice with a fixed dental prosthesis. We are often subjected to a lot of hard and soft tissue concerns, and preservation of hard and soft tissue is very important when we are dealing with the anterior aesthetic zone. So there are different strategies which maintain the hard and soft tissue contours, which ranges from soft tissue augmentation, bone augmentations, guided bone regeneration, and the recent ones are partial extraction therapy, which is socket shield and socket seal techniques. Horizontal bone defects are primarily treated with chin block grafts. This is yet another case where you can appreciate that the central incisor is missing, and because of the trauma, the labial bone is deficient. In particularly this case, a chin block graft is given and waited for it to take up. And only after that, the implant is being placed to have a better osseointegration as well as a better hard tissue configuration. Nowadays, with any form of fractures of the anterior teeth, the socket shield technique or the partial extraction therapies also help us in preserving the labial bone, wherein a part of the tooth, the labial part of the tooth is preserved, and in particularly the palatal segment or the palatal fragment is removed, and the implant is then eventually placed, preserving the labial bone fragment. This would definitely improve the hard and the soft tissue profile in the buccal bone or the labial bone area, and that would definitely help us for our emergence profile. Though these partial extraction therapies have just been documented since a couple of years, it requires a lot of research and scientific evidence for it to be proven to have its success in terms of longevity. Vertical bone defects are most difficult to treat, wherein vertical bone is very difficult to grow. In such a case, a judicious choice of a fixed dental prosthesis with gingival porcelain would be a more preferred treatment modality than dealing with the aesthetic concerns of placing an implant and having it fail. Goodacre has researched a lot regarding the meta-analysis of single abutment versus fixed dental prosthesis, a patient-centered analysis. And he quotes that the preservation of natural teeth is the preferred treatment modality. Why? Oral implants provide an excellent solution should retention through root canal treatment or retreatment not be successful. We certainly have pragmatic and ethical concerns regarding the choice of treatment modality which we are going to offer to our patients. And particularly in India, it is very important for us. The patient has to be educated to understand the needs as well as the possible challenges faced with dental implants. Also, it is not yet dentally insured. On failure of implants, a fixed dental prosthesis is often placed on natural teeth. Then how can it be conferred as an inferior treatment modality? Well, that's a thought that we all must ponder in our minds, wherein implants is not just the panacea solution for each and every edentulous span. Are there any absolute contraindications for implants or FDP? How do we select one over the other? And finally, who wins? Are these the questions that presents with any clinician who is in a dilemma of what is the right form of treatment that we have to choose, not based on bias or not based on any form of expertise? So, well, let's come through a more promising and emerging trends. We all understand that the mechanical and biological implant failures are something which still are a concern when we are treating implants. So today, I'm going to also talk to you about the conometric concept, which is a emerging trend for the mechanical failures, and a one-time one abutment, which is a new way to emerge and combat the biologic failure. This, on the screen, we have a complete analysis of a case wherein we begin with a tooth socket, which has been post-extraction. You can see a tooth socket. Then we place an implant. We have the augmentation of the bone, which is done. Now, what is conometric concept particularly? Conometric concept is something dealing with the form of retention, which is not cement or not even screw. It is based on friction fit. So when we are looking at a screen, when you're looking at this case, the standard abutment, as you can see, after the bone augmentation and the implant is placed, the standard abutment is placed in situ and the conometric cap is now fitted on it. The conometric cap is modified, and on the external surfaces of the the conometric caps are modified, and then after which whichever type of restoration, be it a full linear lithium disilicate crown or a zirconia with layering, is basically locked onto with a friction fit onto the conometric cap. There are special instruments available, and this is one emerging concept to basically prevent the kind of screw loosening or cement debonding which we are facing with the help of mechanical failures of implants. So conometric concept is an emerging new trend. One more concept which is again very, very promising is, all of us are aware that we go through a number of prosthetic procedures after the implant has been placed. And also we have connections and disconnections of the implants, which spreads bacterial contamination, and it disrupts the soft tissue and compromises the epithelial barrier. After the osseointegration of the implant is done, then the healing abutment is placed, the impression copings are placed, and it results in a disruption of the soft tissue attachment which has already been created. The biologic rationale of the use of one-time-one abutment was introduced by Lugo Cannula in 2010, which speaks about that we cannot avoid the inevitable crestal bone loss post-loading, but let us preserve whatever is remaining of the bone and let us not traumatize the soft tissue. Hence, the one-time-one abutment concept took birth in 2010, which basically necessitates the use of a definitive abutment at the time of the implant placement, wherein immediate placement post-extraction is done and you decide the abutment and then you do not remove it. So well, this is yet another case of a fractured lateral incisor. You do an immediate implant placement with provisionalization, the definitive prosthesis is given, and you do not remove the definitive abutment. So if you can appreciate in the RVG and below in the clinical picture, the soft tissue and the hard tissue profile is maintained. There is no bone loss, and that is something which looks very promising in these kinds of one-time, one abutment concepts. Why use it? Well, as I already spoke to you, it prevents marginal bone loss, avoids micro movement, and reduces the number of appointments, and prevents the spread of bacterial contamination of the peri-implant tissues. Single tooth replacements have been very challenging, and obviously they are not supposed to be the dentist's bias or the objective appraisals of treatment options. We all understand that fixed dental prosthesis has a clinical ease, reduced time and cost, as well as a predictability, which obviously would give us that in a short period of time, we could give a fixed dental prosthesis. But our patients are looking at something different. Implant is a long-term solution. It preserves pristine teeth, and obviously the desired aesthetics and function is achieved with the implant if all the decision making is borne in mind. The diligent decisions are not dependent on cost, time, or difficulty to perform a procedure. It's basically dependent on age, patient preferences, and compliance. Also, the oral and systemic conditions of the patient and longevity of the restoration has to be borne in mind. So if we probably revisit, we can say that accurate diagnosis, ethics and principles, patient preferences, and cost-benefit factor will lead us to diligent decision making. Let's all change our conventional and conditional thought process, and let's broaden our horizons. Let's rethink whether we are solved the enigma of whether implant versus FDP is the solution and promising a dental treatment that is more in terms of longevity, in terms of function, as well as in terms of occlusal rehabilitation. Thank you so much. I wanted to wrap up a little early because I know it's the last session and we are open for any questions. Yes, Ruben.
Thank you so much, ma'am. Thank you for the lovely presentation. I'm sure you've enlightened the audience with yet another power-packed session. Ladies and gentlemen, we are open to a question answer session. So for all you lovely people who are interested to ask any questions with regards to the topic, please feel free to post them in the Q&A box. Once again, Dr. Saloni, on behalf of Team DentistChannel.Online, I would like to thank you for making time out in your heavy and your busy schedule. In gracing this event with your presence once again, we truly felt your presence as always, and we always look forward to having you for all our sessions. Friends, once again, I request you to kindly post your questions in the Q&A box. All right, to begin with the first question, what is the success rate of immediate implants?
Well, the success rate of immediate implants in terms of, I would say, meta-analysis would be almost 90 to 95%, particularly when you choose the case properly. As I said, the evaluation of the case in immediate implantation, the hard and soft tissue profile, the bone sounding is very, very important. And that would definitely, nowadays, with the aesthetic concerns, the immediate provisionalization is the answer when you have a good hard and soft tissue profile, which you're going to evaluate.
Thank you, ma'am. We move to the next question. Use of PRF in soft tissue augmentation.
Yes, so PRF is very, very important because it reduces the kind of inflammation, it improves the wound healing, though it would not particularly improve osseointegration, but it definitely improves the wound healing and reduces the inflammation. So PRF is something which can be definitely used. Yes, the patient has to agree to it because it's drawing the patient's own blood. So that's something which the patient has to agree to.
Thank you, ma'am. Next question. Would you suggest tooth and implant supported prosthesis in the posterior region?
Yes, so like as I spoke, that tooth and implant supported, whether to splint or not to splint. Now, as I already spoke, that the tooth has a vertical and a horizontal movement, which is more particularly because of the periodontal ligament, and the implant has a very limited movement because of the viscoelasticity of the bone. So when we are talking about connecting one implant to one tooth and having a fixed dental prosthesis done, then a use of a rigid connection is more preferable rather than using a non-rigid connector, which would be more detrimental because of this biomechanical differential in the mobility of the implant and the tooth. However, there are a lot of studies which talk about just one implant to one tooth and not more than that. We would not like to splint more.
Thank you, ma'am. We move to the next question. What is your take on zirconia implants?
Well, zirconia has been the contemporary dental material. However, zirconia is yet need to prove. Zirconia implants are more particularly used in the anterior aesthetic zone, and it is yet requiring a lot of scientific evidence. So that is something which we need to research upon more.
Thank you, ma'am. Once again, friends, we are open to a live question and answer discussion. If you have any questions, please feel free to post them in the Q&A box. Next question. Immediate loading in mandible after a week of placement. What is your take on this?
Immediate loading of mandible after a week of placement. Okay. So depending on there is nothing called as immediate loading. We have to be free of excursive contacts. So when we are talking about immediate loading post-implantation, it is provisionalization without the excursive contacts, without heavy excursive contacts. When we are talking about immediate loading after a week of placement, then obviously we are again looking at what kind of tooth replacement, whether it's a single tooth, there are multiple teeth, and depending upon the bone condition and the primary stability of the implant, the immediate loading can be considered.
Thank you, ma'am. Next question. Which synthetic bone graft is good?
Well, synthetic bone grafts is something which I am not going to be, it's a clinician's choice. So I'm not particularly going to name which one is good. I guess it's a combination of your particular choice as well as your comfort levels, as well as economic concerns, as well as the residual bone conditions. So it's not something which I would particularly name. I think you have to try your own. You have to have a trial and error basis and decide which synthetic bone graft. There are lots in the market. There are a lot of tall claims as well, but that's something that a good clinician will decide.
Thank you, ma'am. I think this should be the last question. Ma'am, what would be your final take? Would it always be conventional implants, or will it be the new age one-piece implants?
New age one piece implants is again something which it has to be everything that you decide. We are not locked into conventional thinking. As I said, we have to be not locked into a conventional condition thought process. Each case, each clinical case presents a different clinical scenario. So we have to basically tick the algorithms of what is the correct decision planning. In case the need demands a single piece implant, we do that. We have a conventional procedure, we do that. We have a conometric concept, we try and do that. A one point, so every single case has its own decision making. That is the judicious discretion of a good clinician.
Thank you, ma'am. Ma'am, allow me to ask you a few more questions, all these last minute questions which are coming up. Friends,
Sure.
it's a genuine request. Please post your questions as soon as possible. Thank you. Next question from Dr. Amit. Immediate loading is better or delayed in the posterior region?
Well, in the posterior region, I would always prefer a delayed loading or a progressive loading as well, as it's called, because posterior region has more occlusal load. So particularly in the posterior region, I would prefer it. In my prefer as well as scientifically, it is documented that it is better to have a delayed loading or a progressive loading.
Thank you. Next question. In case of bone loss in the anterior region, extrusion of tooth would lead to crown root ratio change. Wouldn't it affect the final outcome?
Well, so when we are particularly talking about a case where, let us say, we have a lateral incisor and we want orthodontic extrusion, the crown root ratio has to be favorable. It has to be a 2:3 or a 1:2. So now when we are evaluating the crown root ratio, only then we would have an orthodontic extrusion to improve our gingival architecture. Again, the decision making is depending upon your RBGs and checking your crown root ratios. And only after that, you're going to decide whether your orthodontic extrusion is going to actually help you. If it's not going to help you, then obviously you're not going to go into intervention in orthodontics. In that case, a fixed dental prosthesis would be your preferred treatment of choice to improve your gingival architecture. Yet another thing is, if your high lip line, your smile line, if your gingival architecture is going to be visible, then it makes sense to have interventional orthodontics. But if it is not, then again, you need to take a call wherein how much of tooth is going to be visible.
Thank you, ma'am. Next question. Immediate extraction and placement for upper posterior with one-time abutment and provisional loading. Is that possible?
Well, in case of anterior teeth, it's more preferable. In posterior teeth, it is not advisable.
Thank you. Ma'am, which one is better, screw retained or cement retained?
Well, it's nothing again of which one is better. So as we clearly know, for a screw retained, for a cement retained, we have to have a restorative space of 10 to 12 millimeters. And for a screw retained, we can probably adjust between 6 to 8 millimeters. So when we have a challenge in the restorative space and lesser than 10 millimeters, then we would opt for a screw retained, and for a cement retained, again, it would be more restorative space. So there's nothing like which one is better again. Again, it's a very, very clinically decision or clinically driven kind of decision.